Chapter 2 starts in with our actual physical exam strategies. I think it does a great job in your book. Again, I would suggest printing these off and maybe using these as you're taking notes or having them as resources for quizzes, etc. I love how they outline all of this. I think the book does a great job. Your function of the physical exam is now really critical to gather your objective data using all of your resources and senses, sight, hearing, touch, and smell. And then in conjunction with our history, it's going to be used for to make the treatment plan. Same thing of this goes into interacting with the patient, is that you're developing a trustful relationship. You have to be very aware with the physical exam of the patient is now in a vulnerable position where there's a change in power. You are now examining them. Part of their body is going to be exposed. It's kind of a different perspective, so we have to be courteous and aware and very professional. When to know how much to do, okay? When you're in clinical this semester, even again, if they come in for the sore toe, I want you guys to be asking them, I know you came in for the toe, but I'm a nurse practitioner student, and this is my clinicals where I'm learning my physical exam techniques. Would it be okay with you if I also listened to your heart and your lungs, and maybe could I look in your ears? I need more practice with that. And ask them and do it. Okay, so you maybe have to ask in those scenarios to do more skills and things. Okay, basically your comprehensive head to toe is meant for getting admitted to the hospital, having to have a procedure, acutely ill, inpatient things oftentimes need a comprehensive. Focus tends to be more episodic care. You go to your PCP or your specialist for an appointment for a specific reason, or you're in a walk-in clinic or an urgent care. So with inspection assessment techniques, right, you're always going to do inspection first. Before you touch, look, or listen, you need to inspect with your eyes, and you're collecting your data of sight and smell. Okay. Then there's palpation. That's your touch, temperature, texture, tenderness, sensation. Percussion is when we use the tapping, creating the sound waves that help us understand the underlying structures. And then auscultation is always last, right? Typically, unless it's the stomach. But that is now your stethoscope, and typically that's used in hearts, lungs, and abdomen. Also sometimes in vascular assessments. It's very important to have a good high quality stethoscope. I don't know that in school you need to spend $400 on some of the newer ones, the digital ones or whatever, but a good quality stethoscope is going to be very important. Make sure before you go in there to do your head to toe, because the patient is probably going to be exposed or in a gown, cold, uncomfortable, as you bring all your necessary equipment with you. Sometimes you have to think about things of, are they in a gown? Do they have to have a full bladder? Do they have to be able to have the gown open in the front, the gown open in the back? Do you need a chaperone? All of those things. You have to remember to respect modesty. I remember learning how to do a bed bath as a nurse, and you would uncover one leg but keep the other leg covered. Same scenario applies to when you are doing a physical exam. Don't just expose large parts of their body for an unneeded period of time. Wash your hands, and then apply gloves. There's very rarely a time when I actually go to do my physical assessment that I don't put on gloves. However, I'm doing a lot of palliative and hospice care. I touch my patients all the time without gloves. I hold hands or I rub their arm, whatever, because I want the physical contact in my role. But when I'm really doing a full physical exam, I wear gloves. Always explain the procedure to the patient. Okay, I'm going to listen to your heart next. Okay, I'm going to lift up the back of your shirt because I'm listening to your lungs. Okay, for this next part, I'm going to XYZ. Your general survey, we're looking appearance, physical exam, their mobility, their speech patterns, and then you're looking for hearing aids, hearing deficits, some of those things as well. Remember, measurements are included in that typically, your height, your weight, your vital signs. So vital signs are part of your physical exam. So if someone says, I need the physical exam, they're also asking for the data of the vital signs. Think about their position. Are they doing where they're seated? Okay, so for this part, they're going to be seated facing an examiner. When you go to do your end of the year comprehensive checkoff, You are doing multiple things, sometimes twice, because maybe the first time you're doing it when they're facing you, maybe the second time you're doing it when they're the left lateral recumbent, and maybe the next you're doing it from the posterior, right? So that's why it's saying patient seated facing the examiner. Okay, so I'm staring them in the eye. Okay, they're seated, I'm examining them face to face. For your head and your face, you're looking at the skin, face, scalp, and hair. You're looking at the strength and symmetry of their facial muscles, the masseter and the temporal muscles, and sensation awareness, cranial nerve 5. Eyes, reflexes, muscles, positioning, alignment, eyelids, eyelashes, lacrimal apparatus, conjunctiva, sclera, pupil reactivity, and fundoscopic exam. So if I were talking out loud and I was doing my end of the year checkoff, I would say, as you're doing it verbally, right? I'm looking at the eyes, I'm assessing their eyelids, their eyelashes, I'm touching their lacrimal apparatus. You're pulling their eyes down to look at their conjunctiva, their sclera. Now I'm going to use this light and I'm checking for pupil reactivity. I don't have access to an eye scope. Oh my gosh, you guys. And so I'm not going to do a fundoscopic assessment. Okay. Next, I'm going to look at their ears. I'm looking at their external structures, the pinna, the auricle. I'm going to palpate for tenderness after inspecting the area. I'm going to look at the outer ear, the inner ear with my otoscope. I'm going to this, I'm going to that. Next, I'm going to use my tuning fork, my pitchfork. Don't use a pitchfork. I'm going to use my tuning fork and I'm going to test for hearing acuity, right? I'm going to do the whisper test. I'm going to do this. I'm going to do that. So as you're thinking of those things, right? So part of the exam that you do is patient seated facing examiner, their eyes, their ears, their nose, their mouth, the oropharynx is all in here, right? So what we're asking you guys to do is by memory, remember these things, right? That you should be able to look at a patient with no notes in front of you and say, I'm looking at their nose and thinking to yourself, I'm going to look externally, I'm going to palpate their nose, I'm going to look internally with the light, I'm going to test their sense of smell, I'm going to plug one nostril and have them breathe in, plug the other nostril and have them breathe in. When I'm looking at their oropharynx, I'm going to look for their mouth, their lips, the appearance of their internal and external structures, their breath odor, their gag reflex, their sense of taste. So they're seated, they're facing me. I'm going to look at their neck. I'm going to look at their inspection of their neck. Then I'm going to palpate their lymph nodes, their carotid pulses, their trachea, and their thyroid. Then I'm going to look at their upper extremities, how they look. Do they have their range of motion test? Do I have their reflexes, their pulses? Is there any tenderness to palpation? Okay. Then there's patients seated, facing away from the examiner, so their back is exposed. Now that I have their posterior chest and back, I'm looking for lesions. I'm looking at thoracic configuration. This is another part where you can assess their spine and their kidneys. You're looking for lung assessment, right? You're listening and auscultating from the back as well. Then you're actually going to also touch their back and do tactile phrematis and those things. Now, if the patient's seated facing the examiner with the chest exposed, that's when you do their anterior chest, thorax, lungs, heart, and breast. Then the patient needs to be reclining at 45 degrees so that we can check for JVD or JVP things. Then I need my patient supine, so now they're laying flat with their chest exposed. Now at this point, I can do a total breast exam on a female patient. I also can now do a complete heart exam with the precordium, apical pulse, borders, and heart sounds. Okay. Then I move down past the abdomen and their abdomen's now exposed, so I'm going to go into genitalia. For the male genitalia, you're going to have the distribution of pubic hair, palpation of the penis, urinary meatus, and testes. You're looking for rashes, lesions, color changes, or edema, and the presence of whether or not they have inguinal hernias. Now they're still laying on the back, now I'm looking down at their legs. First, I'm going to do their hips, palpation of the area, and look at hip range of motion. Then I go down the legs, range of motion, inspection, looking for lesions, discolorations, etc. Okay, now we're back up to the patient seated facing me. This is when I can do my neurologic thing, my reflexes, sensation, dystaxia. Then you have your patient stand and they're going to move across the room to test their neurologic system. You're also going to have them bend and do different positions to test spine. Female patients typically, when you're talking about genitalia, often require them to be in the lithotomy position, where they're slightly reclined with their legs like up in stirrups or their heels on the bed, kind of frog-legged, sometimes they call it, so that you can have the genitalia exposed. This is also when you maybe are going to do an internal examination or a rectovaginal examination. Okay, then they go to, there are some special populations of patients that are, have to be taken into consideration. Pregnant patients, they need to empty their bladder, and you typically do everything when they're lying on their side, because if they're flat on their back with a big round belly of a baby, they can't breathe. We're not worried about neonatal patients, obviously. Pediatric patients, this would include a 13 or 14-year-old that sometimes we are allowed to see. But again, typically by that age, they don't need to be treated as a child per se. Then our geriatric patients, we have to be patient. We have to offer assistance with mobility and perform a functional assessment. How can they get up and down from a chair or the commode? How can they do walking? How can they do laying in bed? Those kind of things. Okay. So I'm just giving a very fast, brief overview of that. I really want you guys to take from this slide that read the book on how you do the physical exams. Obviously, there's a ton more information in this chapter, but pay attention to there are certain things you're doing that require the different positions of the patient in relationship to you. And those are things I want you to know, because at the end of the semester and into immersion, when you show your validation skills of your physical exam, those are something I'm going to expect. I need for you to know that I need to face the patient from the rear with their back exposed. And at this point, I'm checking for A, B, and C. As always, reach out with any questions.